Hello there. This is the third class in the series of clinical pharmacokinetics. Today we'll be focusing on therapeutic drug monitoring. In fact, this class was scheduled on this date, but due to some holiday we couldn't make this class possible. So in near future it will be rescheduled, but anyway I am giving the video lecture to you people today. And before heading to the main topic of today, therapeutic drug monitoring, which would in fact not be more than 2-3 slides, so I will like to give you few concepts that you will find very useful in the days to come in your competitive examinations that you will be facing after you complete your MBBS or BDS, and to understand the working of drugs in the better ways as well. This is very important. So let's get the balls rolling. Okay, so as I have told you in the class earlier, the main aim of clinical pharmacokinetics is to achieve the drug level which is above the minimum effective concentration. Minimum effective concentration at which the drug works, but at which the drug doesn't produce the side effect, or that is minimum below the minimum toxic concentration. And second thing I'll like to ask you or think about this, well, how does this sort of achieving this sort of plasma drug level or plasma concentration is possible? How does this kind of blood level or plasma drug concentration in blood possible? When you take the drug, like if you take the drug orally, after sometimes it will get 100%, it will reach its bioavailability, it will reach its full level, and after sometimes the curve will not go like this, the curve will not progress like this. The curve will, due to the metabolism in our body, it will of course go like this as shown here. And in its half life, if we are supposing when the drug spend the time which is equal to the half life of the drug, 50% of the drug will be gone. So this kind of curve is not possible. And in the further in the time to come, it will reduce such that in 4 to 5 half lives there will be negligible amount of drug in the body, in the body. So how is this kind of curve possible, or how is this kind of curve blood level of drug in the plasma possible? Look, or like in other words, I am telling you that the whatever plasma level you achieve, for example 100 microgram per ml, in one half life it will get reduced to the 50 microgram per ml, and in another half life it will get to 25. So with the curve like this, after some times negligible amount will remain in the blood. So my question is, how will you achieve this kind of curve? Okay, the answer is, this kind of curve is only possible if you give the drug intravenously and continuously. Okay, this is known as, that is giving intravenously and continuously is known as intravenous infusion. Okay, but like you are ill and you want to take cetamol, do you like to get the continuous intravenous infusion of cetamol, or maybe an antibiotic you get an infection, do you like to get the continuous intravenous infusion of antibiotics? You don't like that. So how will you get the drug dose within these two ends, that is above the minimum effective concentration and below the toxic concentration? How is it possible? Look, in intravenous infusion, continuous intravenous infusion, it is possible because, for example, in 1 minute or 1 second the drug is metabolized by 0.5 microgram per ml, but at the same time you are also infusing the same amount of drug. So input or the output, that is drug taken by metabolism, is equal to the input due to infusion. So the curve is like this. Okay, sorry, the curve is like this. It is neither decreasing nor increasing. The slope is neither decreasing nor increasing. So you will not like to get the intravenous infusion for simple infection or maybe for fever. For that you have to get admitted in the hospital because your home most probably would not have this facility of intravenous infusion, and there are many complications likely to be associated with intravenous infusion as well. So how will you solve the problem? Okay, you might be guessing it right. Yes, for this you have to understand this diagram. Okay, look, in this diagram what we have shown is, on the x-axis, on the y-axis is the plasma concentration of drug. It is the plasma concentration of drug. Let's say, for example, this is 20 microgram per ml and this is 200 microgram per ml. This is the blood plasma concentration and this is the time. Okay, this is time. This time we have represented it in the form of T half life. Okay, for example, 4 hours is the T half life. 4 hours is the T half life. So this is the time in the unit of T half. No, it is in the unit of hour, but we have plotted only the T half life, which is equal to 4 hours. Okay, so this is time. So here let's suppose that okay, here we have plotted it for the intermittent intravenous drug, but the same curve, the curve is very similar for the intermittent oral dose administration as well. Okay, the main principle is important. Okay, so what happens is, you can give the intravenous infusion continuously, but if you give the intravenous infusion intermittently or oral dose intermittently, what happens is, in one half life, for example, you give drug such that the drug achieve 100 microgram per ml concentration in the plasma. Okay, you give drug, so instantly when you give the drug intravenously, intermittently means not giving continuously. Okay, once you inject the drug 100 microgram per ml, it will some dose which will produce 100 microgram per ml. So this 100 microgram per ml will in one half life will decrease to from 100 to 50 microgram. Okay, then again you give another dose, and that will increase it to the 150 microgram, isn't it? 150 microgram. Then again in the another half life, it will 150 microgram will get reduced by 50% and it will become 75 microgram, isn't it? And again you add 100 microgram and it will again increase to 175 microgram, and again this is 3 half life, 1 half life, 2 half life, 3 half life. Similarly, after 4 half life, the plasma level of the drug will start to plateau. Okay, what is plateau? Okay, for now just remember that after 4 to 5 half lives, this is after 4 half life, the drug level starts to plateau. That means, look, here from this level to this level, it is a vast difference. It is the difference of around 25, isn't it? From one level to another level, it is a difference of 25. But from this level to this level, the difference is only slight, that is 3. And from this level to this level, the difference will still be smaller, because the plasma level has started to plateau. You know what it means by plateau? Plateau is, okay, this. Forget about the two ladies in front and look behind them. This is the slope, and this is the plateau. This is plateau. Okay. If you remember the oxygen hemoglobin curve also, there is after 3 molecules the it start to plateau, something like that. This is plateau. Sorry. This is plateau. This is plateau. That means it will become labeled, you know. So it becomes plateau. So what happens in here is, why does it is plateauing here? Why does it is plateauing here? Here it's a lot difference, and why it is plateauing here? It's you see, this is the this is called trough, and this is called trough, and this is called peak. This is the peak level, and you can see all the lowest level for that drug is equal here, but here it's not equal. Here it's not equal, but here it's almost equal. Why it is so? Here it's almost equal. It is because here the drug is accumulating. Okay, here the drug is accumulating. For example, drug is cleared 150. For example, in one half life, drug is cleared 50 drug is cleared. The 50 is accumulating, isn't it? But from here to here, only 3 is accumulating. That means 3, and if you progress over here and here, if you go on to the right, more and more right side, then there will be no adding up. What does it mean by adding up or accumulating? Accumulating means input is more than output, isn't it? Input becoming more than output is accumulation. But as you go to the right, the accumulation becomes smaller and smaller, and it is assumed for practical reason that after 4 or 5 half lives, the accumulation is very negligible. That's why it plateaus. So as you give the drug over here, it is input is equal to output, and we call it steady state plasma concentration, CPSS. Steady state plasma concentration is achieved. Okay. Because amount added for one half life is just consumed in that is just metabolized by the amount added before another administration is just metabolized. That is, amount added before next administration is just metabolized. That means input rate is equal to the output rate. So it has become labeled, and yes, it has also because the drug is being administered intermittently. So of course there are peaks, and we have to make sure that this peak is not greater than minimum toxic concentration, and this trough or the lowest point is not less than the minimum therapeutic concentration. We have to make sure. Though we could not produce this thing, though this thing could not be produced, we didn't let this thing as well. Because the plasma concentration is maintained. Of course, we had this ups and downs, but these ups and downs after adding the drug, even after adding the drug, the plasma concentration is not increasing, it is being same, the plasma concentration has become steady, and this is known as steady state plasma concentration. Okay, now the one bad thing about this figure is that you have to wait 4 to 5 half lives to achieve this steady state, isn't it? There are drugs, but there are drugs with longer half lives. Look, here we have waited 1 2 3 4 5 half lives to get this steady state plasma concentration, isn't it? We have waited that much. So what about these kinds of drugs, like which have longer half lives? For example, digoxin has 40 hours, decipramine, and these are all the drugs having long half life. So should we wait for the 4 to 5 half lives? These 4 to 5 half lives would be very long to get the steady state plasma concentration. Again, there are some emergency drugs, like lignocaine, which we need, which steady state we need immediately. Why? Because it is emergency drug used for arrhythmia. Arrhythmia means the heart which is essential to pump is contracting at very irregular way, so that it is not able to pump, and heart pumping is something we need in the moment to moment basis. We need it instantly. We cannot we cannot tolerate it even if it is absent for minutes, isn't it? So can we wait for the 4 hours for it? Can we wait for 4 hours for it, or 5 hours for it? No, it's also not good. So what about these sub-antimicrobials, which need the drug level to be minimum inhibitory concentration, that is minimum inhibitory concentration, to avoid the danger of development of bacterial resistance from the beginning? Just like sulfonamide, doxycycline, they cannot wait for this slow rising. They need it up and fast. They need the blood level up higher and fast. They cannot afford this lower blood plasma drug level. Why? Because they will develop resistance. Because the organism will develop resistance, they will learn to fight against the smaller dose, and they will resist against the higher dose as well. So we cannot afford it. So in 3 situations it is not desirable. So what might be the solution of these 3 ways? Getting the plasma concentration, steady state plasma concentration fast. So what might be the solution for this? Anyone have any idea? Look at this diagram and tell me what is the solution for achieving quick steady state plasma concentration. Okay, look, while achieving this steady state plasma concentration, I have repeated the same dose that produces the 100 microgram per ml in every half life, isn't it? In every half life I have repeated in every half life the same dose. So a smart guy came up with another idea, that is, what about giving the higher dose than one needed to achieve 100 microgram? What about giving one that will achieve 200, so that in one half life it will become 100 microgram per ml? So it is, what it has done is, it has actually bypassed these two, isn't it? It has bypassed these two, and once you get 100 microgram, you continue with the same 100 same smaller dose that will produce 100 microgram per ml, isn't it? So that once you give the larger dose, then you continue with the same dose that will produce 100 microgram. So from here it will go here. So basically what it does is, it bypasses these two and it will directly reach here. So this bigger dose, what is this bigger dose then? Sorry, what we like to call this bigger dose? This bigger dose is known as loading dose or priming dose. This is the single or few quickly repeated doses given in the beginning to attain target concentration rapidly. In our case, target concentration was 100. The CSS or steady state plasma concentration, lower steady state plasma concentration was 100. Upper steady state or maximum steady state plasma concentration was 200. So in our case, we give bigger dose in the beginning to attain the target concentration. Target concentration is, this is target concentration, isn't it? This is the average target concentration, and this is minimum, this is maximum. So this is, and so how will you carry? So whenever we say only say steady state plasma concentration, we mean the average steady state plasma concentration. Okay, we mean this one we mean. So how will you calculate this loading dose? We calculate it in the same way in which we have done previously, where we placed some solute in a tank. Okay, but this time we loading dose, because it will distribute in the volume of distribution. So loading dose we calculate by the very same formula, in which CPSS is the steady state plasma concentration, and we divide this by F. F means the oral bioavailability, because oral bioavailability is fraction always less than 1. So loading dose, because there is loss due to the oral bioavailability, so it tends to increase the loading dose. That's why we divide it with the bioavailability, because it is less than 1, so the amount will be more than, so amount will be more, loading dose amount will be more. I hope you understood this. Okay, loading dose, look, loading dose, by the time we give loading dose, we don't think about the clearance, it is not being cleared. Okay, so the clearance or T half life doesn't have meaning to calculate the loading dose. Loading dose is just like we calculated for the tank. Just suppose our body one compartmental, just like that tank. Okay, to understand this loading dose. Okay, now maintenance dose. Okay, which is in this diagram, which is the maintenance dose? Look, for this, or for 4 to half life, you achieve the steady state plasma concentration, isn't it? 4 to half life, you steady state. So by till here, what happens is, till here you get by now you will get the input is equal to output. So you make it input output. So how can you now further, how can you you make sure that the same plasma concentration, same steady state plasma concentration remains? How can you make sure? You can make sure by giving the maintenance, by giving the maintenance drug, isn't it? By giving the maintenance drug. So what is the maintenance? Maintenance okay, I'm sorry that maintenance dose, okay, it will come, but you first remember maintenance rate. Okay, like the body is clearing the drug, isn't it? Body is clearing the drug. So what you have to do is, you have to give the drug not only once, you have to repeat the drug on and on. So it is time dependent something. The dose is 1. This is okay, it has to be repeated at specified intervals after attainment of target CPSS, so as to maintain the same by balancing elimination, isn't it? So you have to give it time to time. So it is maintenance rate is more meaningful. So it is maintenance rate is must be equal to the input rate, isn't it? And it is equal to, it must be equal to maintenance rate equal to input rate is equal to output rate. It is quite clear, so that the same steady state plasma concentration remains, isn't it? So output rate, it would, the maintenance rate or the input rate, it is the same, they should be equal to the output rate. Now you tell me, what is the factor on which the output rate depends? What is the factor in which the output rate depends? Why do we need to add input? What is the thing which is responsible for the output? What is causing drug out of the body? It is clearance, no? So clearance, it is directly proportional to the clearance. Constant CPSS, that is steady state plasma concentration, is constant. So the formula is like this. And for the first order kinetics, this clearance is constant, as I have told previously. So if you keep it over here and you pull it over here, like maintenance rate divided by CPSS, you can say that maintenance rate divided by CPSS is equal to constant, isn't it? And you can also do something like newer maintenance rate divided by newer CPSS is equal to older maintenance rate divided by older CPSS. For example, the CPSS, though the basic concept is same, if we increase or decrease the dose, if we increase or decrease the maintenance rate, the CPSS, though the principle is same, new steady state plasma concentration could be achieved. For example, you can achieve 100 microgram per ml CPSS, or if you increase the dose, if you increase the maintenance dose also, maintenance rate, then it could be increased to 300 or 400, isn't it? So this formula calculates this. Okay, this formula calculates this. Okay, you look over yourself now. Okay, maintenance rate I told you. Now what about the maintenance dose? Maintenance dose is, for example, it is calculated by the same formula, steady state plasma concentration into clearance, and one thing that you add is dosing interval. For example, you are taking maintenance, for example, you are taking cetamol 4 hourly, then its dose is 500 mg. Now if you take 8 hourly, then its dose will be double. So this is maintenance dose. Maintenance is always a rate, but if we consider about dosing interval, then we can say that it is maintenance dose. I think you got it. Okay, there are few things to consider in practice. Okay, for example, benzyl penicillin, it has T half-life less than 1 hour, and paracetamol, its T half-life is less than 2 hours. So how will we administer this drug? Should we administer it every 2 hours? Look, the margin of safety of this drug is very good. Okay, for example, there is a drug whose T half-life I suppose is 2 hours. Okay, 2 hours, and it has huge margin of safety. Now can we give it, for example, its steady state plasma concentration is above 100 microgram per ml. So how will you like to dose it? Like 100 mg, and then it will decrease to 1, so it will take more than 3-4, it will take 8 hours to achieve this. It will take 4 half-lives or 8 hours to achieve this CPSS, or steady state plasma concentration, and more than that, the dosing will be very difficult to do it in every 2 hours, isn't it? So provided that its minimum toxic dose is very high, what we can do is we can give 100, we can achieve 100 microgram per ml. We can give this big dose, and in the so it is above the therapeutic concentration, but the toxic dose is very high. So in the half-life it will be 500, and in the second half-life it will be 250, and in the third half-life it would be 125. So it is still above 100 mg, and then we can dose it again 1000 mg, isn't it? So it will, yes, the drug will little accumulate, but the dosing schedule will be very easier. And another thing is, its margin of safety should be very high. Or the minimum toxic concentration should be very high, as like this drug. I suppose you got my point. Okay, now we come to the main heading. that is therapeutic drug monitoring or the monitoring of plasma concentration of drugs. Now you tell me whether monitoring the plasma concentration is good for every drug, isn't it? Is it good for every drug? Monitoring the plasma concentration of drug, is it good for every drug? Okay, my answer is no, because yes, it sounds good, but for the drugs known as hit and run drugs, okay, hit and run drugs are those whose effect lasts much longer than the drug itself. For example, omeprazole. Look, omeprazole is the drug which inhibits the proton pump inhibitor responsible for production of acid in the stomach irreversibly, and though we can detect the plasma level for some hours, for 18 hours. Look, we see the drug in the plasma and we observe no drug, no omeprazole, okay, but its action may still be there because it has irreversibly inhibited the H plus K plus ATPase or the proton pump in the stomach. So it does not make sense that we measure its level, because it is hit and run drug whose effect lasts much longer than the drug itself. That is, though the drug may not be there in the plasma, its effect is still there. It's known as hit and run drugs, okay. The similar thing also happens with those which act irreversibly. In my view, like irreversibly, those drugs which acts in the irreversible fashion are also hit and run drugs because their effect lasts longer than their plasma level. So I don't think okay. Anyway, these so in the exam, if you are asked, then just tell them that hit and run drugs, in case of hit and run drugs, or those drugs which acts by irreversible fashion, just like organophosphate or phenoxybenzamin, which is an alpha blocker antihypertensive drug. So in case of irreversible drug and hit and run drugs, measuring plasma concentration is useless. Moreover, for the drugs which are activated in the body, so drugs activated in the body are known as prodrugs. For the prodrugs also, measuring plasma level is not that meaningful, because though it may be, this amount may be huge, you got lots of plasma level, but it is for certain reason it is not activated in the body, so its amount does not correspond its activity or action. That's why it is not good to measure the plasma level of prodrug also. And besides, there are drugs just like antihypertensive whose effect can be easily measured. You take the blood pressure cuff and measure the blood pressure instead of looking its plasma level, which is a quite hectic procedure. Same thing happens with hypoglycemic drugs, diuretic drugs, oral anticoagulants, and for which you measure how much the patient is bleeding. There are some lab tests, just like for warfarin you measure the prothrombin type or PT. So for these kinds of drug also it is not good. And some things for general anesthetic it looks funny, because the patient is knocked down to unconsciousness by this general anesthetic, and you will see whether the patient is conscious or unconscious, or you like to see the plasma level of the blood. Of course you like to see whether the patient is conscious or not, no. So where the therapeutic drug monitoring is finding its place, it is finding its place in drugs with narrow therapeutic window. I'll tell you drugs with narrow therapeutic window later. And in case of the drugs where the population variations are quite large, for example, if I take the antidepressant and Y or Mr. Ram takes the antidepressant, I may have large plasma level of antidepressant, but due to different pharmacokinetic reasons, the Ram may be having only small amount of antidepressant, because these drugs are subjected to the large interindividual variation. So for these kinds of drug also we take the therapeutic drug monitoring. And in case of poisoning, for example, first of all, to confirm whether the person has taken the same poison or not, for example, level of paracetamol, in case of acetaminophen or paracetamol poisoning, you want to test the plasma of that patient, whether he has taken the same drug or not. for that reason, and also for other reasons like how worse the person is going to suffer. For these reasons also, also known as prognosis. For prognosis also, the detection of amount of poison in the blood is important, and earlier you detect, the better it is. And there are certain cases in which the drug may not show response. For example, it is quite significant in case of antimicrobials. For example, Mr. X started taking one antimicrobial, and he has something known as natural resistance to that drug. Naturally, he can degrade that drug, then its effect will not be shown in him, and this is known as the failure of drug response. And this is one example. So if there is failure of drug response but no apparent reason, then also we test the amount of drug in the plasma. And there are some the people who don't want to take the drug, and again there are people who forget to take the drug. So to see whether the patient is taking or not taking the drug, we like to see the plasma level to rule out the compliance issue. And in case of certain drugs like aminoglycoside, vancomycin, which are avoided in case of renal failure, but if we have to give the drug anyhow, then we like to see what level of plasma it produces. So in those cases also we like to see this plasma level of these kinds of drugs. Okay, in case of organ failure, this drug is harmful to the kidney, but in some diseases, in some cases, when we don't have option, we have to give these drugs, and in that case, to avoid toxicity as much as possible, we see the plasma level of these drugs. Now I told you I'll tell you about this narrow therapeutic window drug. So okay, look, what about this drug acetaminophen? Is it narrow therapeutic drug? Its therapeutic level is at the upper therapeutic level is 25 microgram per ml, and its toxic is 250 microgram per ml. You see, if you divide by them, it is 10 times. For example, a person is taking 500 milligram to produce 25 microgram per ml. To get toxic level, he has to take 10 500 mg tablets, isn't it? So it's not a narrow therapeutic window drug, because you will see in the next slide what are the narrow therapeutic drug likes. Okay, look at these drugs. Digoxin, it is an antiarrhythmic drug. If you keep the level between 0.8 to 2, then it is therapeutic. Okay, it is therapeutic. But if you go above 2, then it might be toxic. You see, so one thin person, maybe one fat person, one not fat, well built person may be producing 2 nanogram per ml with one small tablet. But if the same tablet is taken by a thin built person, then it might get poisonous to him, isn't it? Because above 2 nanogram per ml, it might get toxic. So this digoxin and many other anti-arrhythmic drugs, arrhythmia I told you before, many other anti-arrhythmic drugs are considered as narrow therapeutic drug. Again, carbamazepine and phenytoin, these are anti-convulsant drugs, okay, anti-seizure drugs. Look, 12 microgram per ml is safe. Just above 5 to 12 microgram is therapeutic. Just 12 could be toxic. Again, phenytoin, for example, one person is taking 1 tab of phenytoin, that is producing 20 microgram per ml. For certain result, if he takes by mistake 2 phenytoin tablet, it might produce 40 and it might get toxic. Isn't it small margin? Similarly, theophylline above 20 might get poisonous. You know why? Because theophylline, as I told you before, it undergoes the zero order elimination kinetics, and once its amount is above certain level, it will follow the zero order kinetics, in which the plasma level will accumulate in a flash, okay, in a flash. And gentamicin, theophylline is an anti-asthmatic drug. It is an anti-asthmatic drug. And similarly, gentamicin. Gentamicin is an aminoglycoside antibiotic. So it is also above 12. It is quite toxic. So it is also narrow therapeutic window drug. Whereas at 10 it might be therapeutic. Similar is the lithium, which is used at the level of 1.1 milliequivalents per liter for acute mania. If you go above 1.5, then it might get toxic. So it is also narrow therapeutic drug. Amitriptyline, the lithium is a drug known as mood stabilizer, which is given for the patient suffering from bipolar affective disorder. Now regarding amitriptyline, it is antidepressant drug, and it is around 4 times. If you increase the drug 4 times, then it is poisonous. Around 4 times it is poisonous, or 3-4 times it is poisonous or toxic, but the toxicity is very, very high. So it is also this antidepressant is also narrow therapeutic drug. Look, here the drugs are the margin between the one used in therapy. For example, in this margin between the therapy, for example, in this drug, for example, gentamicin is 5 to 10. So you can go, one person may be taking 10 microgram, no? So it's if he goes to the 12 microgram, then it is toxic. So margin between the therapeutic level and toxic level is not very high. So it is known as narrow therapeutic drugs. Now, as I have told you previously, these are the antiarrhythmic, like we see digoxin, anticonvulsants, we see phenytoin, and we see carbamazepine, and tricyclic depressant, we see amitriptyline, aminoglycoside, we saw gentamicin, methylxanthine, we saw theophylline, and mood stabilizer lithium, tricyclic, and it's a repeat, and few of them, their metabolism becomes goes from first order to zero order. That's why they are very dangerous. For example, is theophylline. Theophylline is methylxanthines. Look, this is the instrument that we use for therapeutic drug monitoring, or TDM, in our lab, in our pharmacology lab. This is known as SPLC machine. This is the machine. This is we are operated through a computer, but this is the machine, and this we call high performance liquid chromatography. This is based on the principle of chromatography. That's why we call it chromatography. Okay, so that's all for today. Please make sure that all of you get my video lectures, and please suggest me in about the ways in which it could be improved. Thank you.